Yeah, so Hodgkin lymphoma is a setting where antibody-drug conjugates have really found a home, and we're very familiar now with Brentuximab vedotin, initially developed in patients relapsing after autologous transplant, then brought prior to the autologous transplant in some patients. The AETHERA trial looking at consolidation or maintenance after a high-risk autologous stem cell transplant, showing a progression-free survival benefit, and then Echelon-1 comparing BV-AVD with ABVD, which showed a progression-free and now a small but significant overall survival advantage. So, definitely found a home in many settings: frontline, relapse pre-autograft, maintenance post-autograft, relapsing post-autograft. But there are newer antibody-drug conjugates as well, which are being investigated. The one that's probably got furthest so far is Camidanlumab tesirine, or Cami. This is a targeted antibody against CD25, so a different target from Brentuximab, which is CD30. CD25 is on some cases of classical Hodgkin lymphoma, the Reed-Sternberg cells, but it's also on regulatory T cells. So it may be having an immuno-oncological effect by depleting regulatory T cells and allowing the immune system to then attack the Reed-Sternberg cell. It's been through now a phase 2 trial with over 100 patients, and it's certainly very active, with overall responses of around sort of 70% and complete remission rates at around 40% in very heavily pretreated patients. The issue with it is toxicity. So there are toxicities related to the warhead, the PBD dimer, which is the warhead in Cami, and those are, they can be problematic. A rash it can cause, which can be a bit of a pain. It doesn't necessarily go quickly when you stop the treatment. Can cause some fluid retention, which is usually fairly easily dealt with, and it can upset liver function in a proportion of patients, which again is usually reversible. The one we worry about, though, is more of an immune side effect, and that's Guillain-Barré syndrome or polyradiculopathy, which can be very serious in some patients and not necessarily easily reversible. And it seems to happen in between 5 to 10%, so maybe 6 to 7% of patients. We saw it in the phase 1 and we've seen it again in the phase 2. And we can't really necessarily predict the patients who are going to get that. So, it is a very active drug, and it's very useful for patients failing a PD-1 inhibitor and Brentuximab, where there's not many options. Whether it's got a future to come in earlier lines of treatment or in combination, I think is less clear due to these toxicity signals. But I think we're only going to see further development actually of other antibody-drug conjugates in this space, as well as obviously in other lymphoma and cancer targets.